Hello and welcome to today's webinar, Accelerating Primary Care Innovations through Medicaid Managed Care in the Time of COVID-19, made possible by the Commonwealth Fund. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Tricia McGinnis, Executive Vice President and Chief Program Officer at the Center for Healthcare Strategies.
Thank you, Travis, and welcome everybody. Travis, next slide, please. Thank you. My name is Tricia McGinnis, and I'm the Executive Vice President and Chief Program Officer at the Center for Healthcare Strategies, and we are so pleased that you have joined us for today's webinar. It has been well established that robust primary care is an effective means for improving health outcomes, lowering costs, and reducing health disparities. Advanced primary care approaches are particularly important for Medicaid beneficiaries in helping them attain their best possible health. State Medicaid agencies have a powerful role to play in supporting advanced primary care, especially in the context of Medicaid managed care. And states have a wide range of levers at their disposal that they can use. This is particularly salient during COVID-19, where primary care is vital to supporting patients with COVID, but also supporting patients with increased behavioral health and social care needs using telehealth to access service. And that is the focus of today's webinar. After a brief welcome and introductions, we will quickly set the context for what we mean by advanced primary care and what are the key levers that states are using to promote uptake and adoption of advanced primary care. We will then dive into the heart of our webinar with a panel discussion among experts in the field and include plenty of time for audience questions so that we can have you all really engage with the panel as well. I want to thank again the Commonwealth Fund for supporting this webinar and CHCS's work in this area. Next slide, please. For those of you who may not be familiar with CHCS, we are a nonprofit policy center focused on improving the health of low-income Americans. Our work centers around delivery system and payment reform, integrating services for people with complex care needs, and building Medicaid leadership capacity. We focus on knowledge development, collaborative learning, technical assistance, and best practice dissemination. Next slide, please. I'm so pleased to welcome our presenters and panelists here today. I'm going to turn it over soon to Lori Zeffron, Vice President with Delivery System and Payment Reform at the Commonwealth Fund. Then my colleague Kelsey Breichman is going to give a quick overview and context setting around primary care, what we mean and what levers states are using. And then I'm pleased to have as part of our panel, Dr. David Kelly, Dr. David Labby, and Dr. Judy Zerzan-Thule. And with that, I'm going to hand it off to my colleague, Lori Zeffron with the Commonwealth Fund to provide an overview of their work around primary care. Lori?
Great, thank you. And very excited to be here with all of you today. And thanks for joining. This is really an important area of focus for the Commonwealth Fund. If you go to the next slide, please. When we think about our key areas at the Commonwealth Fund, one of our goals is to, in the delivery system reform program, is to achieve greater equity in healthcare delivery for people vulnerable to inequity. And one of our key strategic levers really focuses on promoting payment and policy reform through Medicaid that can impact delivery systems, and also promoting high quality comprehensive primary health care. If you go to the next slide, please. We all know that evidence shows high quality primary health care is associated with improved health outcomes, decreased health disparities, and reduced health care costs. And there's a huge opportunity to promote and advance health equity through primary health care. I think Kelsey will go into this a little further in terms of the key attributes around primary health care. But really, when we think about primary health care, next slide, please. When we think about primary health care, it's really critical to think of it from the perspective of incorporating multidisciplinary teams and integrating digital tools and also community engagement. Next slide, please. And we see with COVID-19 just the significant importance of primary health care and supporting primary health care, particularly during the pandemic. Primary care practices have been significantly hit with financial losses, changes in visit volumes. There's also have been opportunities to innovate, particularly around telehealth and expanding opportunities for telehealth so people can still get the care that they need. And also in terms of COVID-19, that's also highlighted the serious inequities we have in our society, particularly around systemic racism and how that impacts access to care and outcomes. And so when we think about primary health care, it's really important to think of it through that lens in terms of how can we support primary care practices, how can we support safety net practices, and how can we ensure that Black, Indigenous, and people of color also have access to high quality primary care. And I think this will be even more important as we hopefully see our way through this pandemic and see more people coming into the healthcare system for chronic needs that may have been missed or they may not have been able to address during the pandemic. And the last point I'd like to make, if you go to the next slide, is around primary health care and health equity. We often equate primary health care as a key piece in achieving health equity, and it is an important part of the puzzle. It's also important to address universal coverage and address health system bias and addressing systemic racism, and really having key policy changes that together with primary care can help achieve health equity. So really excited about this work and excited about this conversation today. Thank you everyone for their time. I'd also, next slide, like to thank my team as well. So Yafet Getachew, who's a program associate in delivery system reform, and looking forward to the rest of the conversation today. Next slide. Thank you all.
Thank you so much, Dr. Zephyrin. We so appreciate your comments and your support of this work. Part of the portfolio that the Commonwealth Fund has invested in has been a project that CHCS has been leading over the past 2.5 years to really assist 10 states that you see here in both developing advanced primary care models, building on the primary care building blocks that they had invested in previously, and then using their managed care contract levers to really advance those models, to incentivize uptake, to work with their MCOs to really promote the models, and really help drive the work that needs to happen on the ground. Next slide, please. Just earlier this week, as a culmination of all of that work with the 10 states, we released a primary care innovation toolkit. The toolkit provides really practical information for states that they can use to design their work and to help launch it. It explores practical implementation considerations for advanced primary care, provides a lot of details on state examples, including some of the states featured on today's panel, and provides sample managed care contract language so folks can really easily see how to embed this work within their managed care contracts. Next slide, please. And we are excited to announce that with the support of the Commonwealth Fund, we will be launching a next phase of this work comprised of 2 key pieces. The first will be to work with a set of 4 states to be selected who are interested in, who are committed to promoting health equity by using advanced primary care models and their managed care contracts to accomplish that. So stay tuned for more information on that in January. We will also be launching a virtual learning series that will dive much more deeply into these topics and into the various aspects of advanced primary care and the levers that states have to promote that. That webinar series will launch next year as well. So stay tuned as we move ahead in this exciting next phase of our work together in this space. And with that, I want to turn it over to my colleague, Kelsey Brakeman, to really set the stage and the context a little bit more in teeing up our panel discussion. Kelsey?
Thank you so much, Tricia, and thank you everyone for joining us today. So to provide background before we launch into our panel discussion, I'm going to provide a brief overview of state approaches and levers that can help drive primary care innovation. Next slide. Over the past 2 years, through the Primary Care and Innovation Initiative, we've explored both core primary care features and managed care levers to drive primary care uptake. This framework can be used by policymakers, managed care organizations, and other stakeholders to define primary care goals and advance innovation. So through the next few slides, I'll provide a brief overview of each of these in turn. Next slide. First, innovative team-based care models, often employing staff with diverse expertise and backgrounds who can collaborate to provide high-quality care to best meet patient needs. States can support team-based care through managed care in a variety of ways. So as just one example, one strategy is to integrate specific types of staff, whether it's community health workers, peer providers, pharmacists, or others into care teams. COVID-19 has further heightened the need for staff, such as community health workers and patient navigators, to help address health-related social needs and support an equitable pandemic response. Next slide. Telehealth is also a key strategy for increasing access to care, as well as expanding and enhancing the capacity of providers. This includes models in which consumers access services directly, whether it's through video, phone, or other modalities. States and plans can also support provider-to-provider models, such as Project ECHO, in which specialists support primary care providers in caring for patients with complex needs. And as Lori teed up, clearly COVID-19 has resulted in rapid adoption of telehealth. So going forward, one thing for states and plans to consider is how to sustain these innovations, as well as how to optimally use telehealth to improve quality care and support equitable access. Next slide. Within the US, behavioral health conditions, including mental illness and substance use disorders, are often underdiagnosed and treatment is subsequently delayed. Again, COVID-19 is compounding this issue. For example, a CDC survey indicates that US adults report considerably elevated adverse mental health conditions associated with the pandemic. One way states can support behavioral health integration is providing things like training, reimbursement, or other supports to support integrated models that include behavioral health staff. Next slide. In addition to behavioral health integration, primary care plays an important role in identifying and addressing health-related social needs, whether that's food, housing, transportation, or others, lack of which can negatively impede patient health. As with behavioral health, COVID-19 has furthered the need for integration between primary care and social services. Job loss and economic uncertainty, as well as social isolation, is increasing the need for social support. States and MCOs can take steps to address social needs, such as through screening or helping provide or support primary care providers in providing navigation services. Next slide. Again, to reiterate some of the points highlighted earlier, high quality primary care can play an important role in helping mitigate the impact of income inequality on health and reducing race and ethnic disparities. While health and social inequities are longstanding, COVID-19's disproportionate harms to communities of color and low-income individuals really underscores the need for health equity to be a core focus of healthcare in general, and certainly within primary care as well. States and plans can consider strategies to identify and measure health disparities, as well as working with communities and community members to tailor care delivery to promote health equity. Next slide. Through the Primary Care Innovation Initiative, CHCS has also examined and identified ways that states can actively promote those core features via managed care contracting. Promoting managed care organization accountability, advancing value-based payment, and further investing in primary care can be used as mutually reinforcing mechanisms to incentivize and pay for advanced primary care. First, managed care organization accountability mechanisms can set contract expectations and incentives. As one example, this can include incentives such as tying a portion of managed care payment to primary care quality measure performance. Additionally, value-based payment mechanisms seek to transition provider payment away from fee-for-service, which rewards volume, to new payment arrangements that reward value. In light of COVID-19, states may particularly consider how to advance models that stabilize primary care payment and provide additional flexibility for providing care in ways that best meet patient needs. And then finally, an important consideration is how to rebalance overall healthcare spending and invest a higher proportion of spend in primary care. Policymakers can take steps to increase investment by both measuring primary care spending and setting targets for primary care investment. Each of these three levers are broad-based levers that can be used and adapted to support or incentivize any of those 5 core attributes that I previously discussed. So for those of you interested in diving deeper, each of these features and strategies is discussed in more detail in the CHCS Advancing Primary Care Toolkit that Tricia flagged in the intro. And with that, I will turn it back to Tricia and our panel for a deeper discussion into how states and plans are implementing some of these strategies.
Thank you so much, Kelsey, for that context setting. Next slide, please. I am thrilled to introduce our panel participants today. They have worked closely with us throughout this project, and I really welcome the opportunity for you all to hear from them about their work and how their work is evolving with COVID. First, I'll introduce Dr. David Kelly, who's the Chief Medical Officer for the Pennsylvania Department of Human Services, Office of Medical Assistance Programs, and the Office of Long-Term Living, where he helps manage the clinical and quality aspects of the medical assistant programs for over 2.9 million enrollees. He has served on national committees such as the National Quality Forum and NCQA, as well as the CHPRA Pediatric and Medicaid Adult Quality Core Measurement Set work groups. He's a longstanding member and past chair of the Medicaid Medical Directors Network. Dr. David Labbe was the founding Chief Medical Officer of HealthShare Oregon, a coordinated care organization serving nearly 40% of Oregon's Medicaid enrollees, and continues to consult as their health strategy advisor. He previously was the medical director at Care Oregon, the state's largest Medicaid managed care plan, where he developed and oversaw a number of initiatives to develop integrated primary care and to improve care for complex populations. Dr. Judy Zerzanthul is Chief Medical Officer for the Washington Healthcare Authority, which administers the state's Medicaid program and the state's employee and retiree benefits. Dr. Zerzanthul has held leadership positions in the Medicaid Medical Directors Network as well, and has served on a number of committees nationally, including for AHRQ, NQF, NCQA, NASHB, PCORI, and CMS. So welcome, everybody. If this time, if the panelists want to turn on their, that would be great. Terrific. Just wait for Dr. Kelly and Dr. Labbe. Great. Okay, so thank you all so much for being here. I know you're super busy with COVID, so appreciate you taking the time. Let's get things started. You know, the first question that I have for you all is really around the intersection of primary care and COVID. No doubt, diverse low-income populations enrolled in Medicaid have borne the brunt of hardships that COVID-19 has wrought, and they continue to do so. As Medicaid leaders, I would love to get your thoughts on how primary care fits into the current context in addressing some of those issues. You know, how might states strategically use this crisis to strengthen our primary care system and disrupt the status quo so that enrollees can enjoy better and more equitable health? And when it comes to strengthening primary care, what opportunities are really top of mind for you? So Judy, we would like to start with you first. Welcome you to share your thoughts on that topic.
Yes, great, thanks. So in Washington, we're very advanced in a number of areas, and primary care is sadly not one of them. So one of the things we've really been working on over the last year and a half is how do we really advance primary care in Washington state? And we've been looking at it with a multi-payer lens. So it's not just Medicaid, because to get Medicaid or providers that see Medicaid to change, it really helps if there's alignment across all payers, and it makes it easier for clinicians, alignment on both sort of the quality metrics and kind of what is expected in terms of medical hominess, but also alignment on payment, which I will chat about later. And I think for us, we really see strengthening and supporting, i.e. paying more for primary care, as keys to getting access to healthcare, particularly for more vulnerable populations, and also for affordability across Washingtonians. And so we started with this model and a multi-payer table and a primary care summit group of different types of clinicians, nurses, doctors, urban to rural, all different sorts of primary care specialties to create this plan that we have out on our website. And we're just starting to dig into the implementation details. And I think using tools like telehealth, virtual visits, email, sort of different ways of communicating with patients is going to be key that, has been, I think, rapidly developed in primary care because of COVID. And then also thinking about how important the behavioral health integration is and social determinants are. And so we've done some work there too. So.
Great, thanks, Judy. David Kelly, I would love to hear your thoughts from the Pennsylvania perspective and the priorities that you all have set in your state.
Sure, thanks. Again, we've had a patient-centered medical home program since 2016 and have over, I believe, 1,500 practices that are engaged in that particular program. And it serves about 800,000 members, many of which, over 100,000 of those members actually have persistent serious mental illness. And we want our patient-centered medical homes to be very focused on that population, especially during COVID. One of the things that we do in that program is we, allow our managed care plans actually pay our patient-centered medical homes a per member per month, so that there's actually cash flow. Many practices, if they're still on a fee-for-service model, it's very difficult in these times where volumes are down as far as patient visits. So we want to make sure that there's a PMPM that continues to flow to these practices. We also have broadened our telemedicine coverage considerably because we know that that's a huge tool in the toolbox for our primary care practices. We also have allowed in our patient-centered medical home, we've encouraged this behavioral health, physical health integration so that there are some practices that actually have integrated practitioners into their particular practice. Our FQHCs can actually bill for both a physical health and behavioral health visit on the same day. So we're really pushing that integrated care model. The other thing that we have done, and this relates to the social determinants of health, is our patient-centered medical homes they're actually required to do social determinants of health screening on their members at least once a year. And that has been really helpful, we think, during the pandemic to really start to look at what needs are actually, what are the non-medical needs that are out there that folks are facing that, were very different, let's say a year ago. And then lastly, we have a patient-centered medical home learning network that continues to meet virtually. It's statewide and regionally. And it's been good during these trying times to be able to, again, share best practices, lessons learned, and challenges. Thanks.
That's great. And we'll definitely pick up on this theme of payment and how, what role that needs to play, especially given the decline in patient volume and the fact that telehealth doesn't quite make up for that. But David Labby, would love your perspective in advising the CCO in Oregon. You know, what are your thoughts on, you know, what are the opportunities really for primary care given COVID, and what role can states play in supporting that?
So yeah, thank you for asking. I mean, I'd start by saying, I think relative to what's happening nationally, Oregon is pretty far ahead in terms of primary care innovation and medical home development. We've for years had our own medical home standards. Behavioral health integration is widespread. Most practices have some sort of behavioral health consultant. We use a lot of telehealth, et cetera, et cetera. So we've been pretty proud of our primary care work, although we have a ton to do. Most recently, we've been focusing on bringing addiction medicine into primary care by expanding medication-assisted therapy, et cetera. So it was kind of a shock when the COVID response completely ignored primary care. So this COVID response was very public health based. And we actually, from the primary care side, went to the state and said, hey, you know, these are our patients. We might be able to help. They said, no, we have this. Don't worry about it. We'll do the contact tracing, blah, 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 blah. And now what's happened in Multnomah County, or the Tri-County area around Portland, is because of community spread, the pandemic has totally overwhelmed the public health system. And now really primary care needs to step up. But there's no real connectivity between public health and primary care. So I would say one of the major things that states can do is rethink the relationship between public health and the healthcare system. I mean, public health has been underfunded. I completely acknowledge that. Some of my best friends are in public health. It's not their fault, but we need to rethink this model. And you know, I think when we start thinking about primary care and the models that you showed earlier on, yes, we had connection to community there, but there was no connection to public health and cross-sector. So to us, I mean, all of these issues are cross-sector issues. All of these issues are enwrapped in public health. So I think the opportunity here in COVID is largely about rethinking primary care. What is primary care and how does it fit with the rest of the system? And how do we move much beyond simply asking for payment? I mean, we can do the risk, I think, is that we sort of default to doing what we've always done a little bit better, but that's still not going to get us to where we need to be. And I think this will be exacerbated for two reasons. One, we went through a period initially where a lot of practices became financially non-viable. A lot of that was driven by the inability to get PPE, et cetera, which has now somewhat been solved. But given what's happening this winter, there may be more practices at risk. So I think states really need to look at their networks. A managed care organization really needs to look at their networks. And I think this helps push even more the stuff that David Kelly was talking about and Judy was talking about in terms of what's the payment model that allows primary care not to be driven by fee for service, but to ride these bumps, which are going to be probably reoccurring. In Oregon, we also had a huge outbreak of wildfires. Again, different practices were burnt to the ground. So, I mean, so I think we need to rethink primary care in a much different way. There's other ways in which we can talk about this later, but I think that those are two huge opportunities. And I think finally, the whole thing that's going to happen with vaccination is going to be about trust. It's going to come down to trust nationally. I don't know about your communities. I think our communities, we haven't had the pushback on COVID disbelief that some communities have had. But I think primary care plays a huge role in reconnecting trust and getting people to take, which is a medical intervention. And we're going to have to step up and help get the population immunized, however that looks, whatever the vaccine is. If it's 2 doses, who calls them for the second dose? Lots of logistics. But I think we've learned through the last months of political debate, trust, belief in science, belief in the medical system is a huge issue. But when every survey I've ever seen about primary care, people may hate the primary care system, they always like their doctor or their provider. And I think that is the engine, that relationship between one human being and another about their health issues is what can help. So how do we build that? How do we use that? And I think that's part of the conversation with public health, is that public health needs us, we need them, we all need to work together.
That's great. And I, just building on that too, and weaving in some of Dr. Zephyrin's comments, the intersection of trust and public primary care and community engagement, right? Really, this is an opportunity too for primary care to build on its nascent efforts around social determinants and the partnerships that it's begun to build with CBOs to really help partner with them as well on that trust building and vaccination message for sure. So, pivoting on that issue of social determinants, I'd love to hear from each of you briefly around, let's just drill into that a little bit more. Those were clearly urgent within Medicaid before COVID. As Kelsey noted, those have only grown over the past 9 months. So I'd love to hear about the approaches that you all are taking to leverage managed care and support primary care providers in addressing social determinants of health. The work has always been hard to make time for, but obviously primary care teams recognize the importance. So I'd love to just hear, in the context of COVID, what changes are you contemplating around social determinants of health, or what are some of the practical things that you've been doing within the primary care work that you are advancing to really help even, take further the social determinants of health work? So David Labby, I'm going to actually turn to you first for this question.
So I can start by just saying briefly what we have done. When COVID started, HealthShare and its partners, we cover about 360,000 people at this point, and we're not different than other CCOs. But what we did is we started doing outreach. Just anybody who met one of the high risk criteria, chronic disease, age, behavioral health conditions, and we actually tried to outreach to 20% of our members. That's a huge number of people. I don't know. I don't have the exact figure about how many people we actually contacted because there's, but what we found, of course, was huge needs, and we didn't find any surprising needs. I mean, this epidemic of social need has been there long before. COVID just made it worse. Huge issues with food insecurity, huge issues, worry about social isolation, housing, et cetera, et cetera. Lots of work to be done in terms of rationalizing medication delivery, lots of work to be done in terms of supporting people with chronic diseases, et cetera. But that outreach effort was really a community effort. We used staff in clinics, doctors, medical assistants. We used medical students. We used community-based organizations. So it was sort of a sudden, I mean, we talk about how there was a sudden shift in telehealth. Well, there was really a sudden shift in kind of how we engage with the communities around social needs. And it gave us a vision of what a Medicaid plan could do. Given the fact that we have this epidemic, which is, I've said, has basically been there all along. Some of the questions that came out of that are really, okay, so we identify all these people with food insecurity. How do we get them food? We have sort of, we use the resources that have been there. We don't have standard relationships. So it's raised the issue of how do we connect the healthcare system to the social service system and to the community-based organizations in a much more structured way. Which are the organizations that can actually deliver? Where do we want to invest? What kind of contracts do we need? What's the role of community-based organizations, community health workers? So I think it's really begged the question of what is the social health model that we are trying to build and what are the pieces of it? We have, the CCO model has from the beginning included a focus on community health workers. And what we've done is we said, well, we have a diabetes program, we need a community health worker. Well, we have an MAT program, oh, we need a community health worker up here. They've always been patchwork, and suddenly it's gotten to the point where there's so many of these things, you can't ask a clinic to have 7 different community health workers working on 7 different projects. We've got to have a community health worker strategy. And what does that strategy look like? How is it funded? What's the training? What is the intersection? So it becomes much more of a systemic approach to including community health workers. And I would even ask, do these community health workers live in the clinic, or are they basically in the community-based organizations, which I think is probably the optimal model. The other thing that we have done Finally is we have invested in actually statewide technology to connect social services. We use the Unitas framework. It's called Connect Oregon here, but it's a way that primary care practices, or any medical practice can access services, make sure there's a connection with the service provider, there's a feedback loop, but it also is going to give us an incredible amount of data about what the social needs are. So we actually can see what it is that will help drive where we need to invest, what kind of system we need collectively to build, because that's because we haven't had data before, and now we will actually have statewide regional data that we can start creating basically a health strategy for a community. So I think, I mean, this goes back to the technology point, and there's so many of these technologies out there. We chose one, you can choose any one, but I think states have a huge role to play in creating the information technology, which will lay the foundation for creating a new kind of care, which is much more holistic and integrated and cross-sector.
Great. Thank you so much, David, for sharing what's going on in Oregon on that front. David Kelly, you had earlier mentioned work within your PCMH program around social determinants. Can you talk a little bit with us around how that's playing out in COVID, what kind of pivots you all have made or deepening of your work that you've done in response, given that foundation that you had in place before the pandemic struck?
Sure. As I mentioned previously, our patient-centered medical homes for the last 2 years have been required, and it's a contractual requirement through our managed care plans that at least once a year that they should use a validated screening tool to look at the various social determinants of health. So we've been collecting data, and actually we've given them guidance on putting in Z codes into their claims. So we have information. It's not perfect, but we have information that we're also, we want them to use that information. And what we found is that, housing and food insecurity are kind of number one and number two. And especially during COVID, I think that those are just vitally, vitally important. So we've asked the patient-centered medical homes to, identify those needs. But again, the key issue is what are the resources within your community, and how do you get them there, and how do you make sure that they've gotten there? And our patient-centered medical homes are doing that, but we also want them working with our managed care plans. We actually have an RFP out now for something similar to the Unitas program that Oregon already has, where we're hoping that we get a statewide vendor system so that providers, our MCOs, and community-based organizations can all be talking into the same system, and there will be the ability to refer. You'll know the resources within your community, you'll be able to refer, and then you'll also be able to track. So we're really excited about getting that up and running in 2021. We think that's really vitally important. But even so, with some of the things that we did in our patient-centered medical home program, those practices were already looking at those needs and how they were changing during the COVID pandemic. Lastly, the other thing that we are requiring next year in our contracts with our MCOs is that they actually work with key community-based organizations to develop value-based arrangements with those community-based organizations. So we're dipping our toe into that realm starting in 2021 through, again, we're requiring our MCOs to start to put those arrangements into place.
That's really exciting. Thanks for sharing that. I'll definitely look forward to hear how that's going in 2021 for sure. Judy, in the interest of time, I would love to hear a little bit more about what you all have going on in the payment realm in Washington State, because I know that is something that you had in the works before COVID struck, and that this really accelerated your work in this area. And I think what you all are doing is just incredibly innovative. So I would just love to hear from you a bit more about the approach that you're taking. What the model looks like, feedback that you've gotten from your stakeholders in your community. I know you've done a lot of stakeholder engagement. So could you just kind of flesh out that picture a little bit for us? Because I think it's really fascinating.
Sure. So I've said this before, it might be a little bit of a repeat, but I liken traditional primary care to a combustion engine car, and it works a certain way and it gets paid for a certain way. You have different kinds of gas, but it's all kind of the same. And we are changing that model. We are moving, it is past time. We are moving to the electric vehicle. So the whole innards of primary care are out. The ways of doing things are out. It's time to sort of restructure and realign on some of these things that we talked about today that are super important for primary care. So we are moving to electricity, a sustainable model. We have a 3-part payment system that we've developed through our multi-payer, multi-stakeholder work. 1 and 3 are related to each other. So the first part is a transformation fee that can be paid to practices. As I mentioned earlier, Washington's a bit behind in this. And so that transformation fee is designed to help practices get what they need to do. We just this year have all regions of our state now in fully integrated managed care. And so that's trickling down to practices, but this fee is designed to help practices get where they need to be ready for this. Practices are ready, and I will say we have some fantastic practices in Washington that are ready. They don't have to do that. They can just flip to the third part of the payments system, which is a risk-adjusted quality payment that you earn based on attainment of structural measures that are PCMHE and also more traditional quality health outcome HEDIS kinds of measures. But the bulk of the payment to primary care is per member per month, or a capitated sort of payment that is for all those things. And we're hoping that then that allows a practice to really use the whole team and to provide care in different ways that aren't just the face-to-face interaction. And I think that'll also help with some of these health-related social needs that are often discovered in this. I will say to the last question, one of the things that we discovered starting to work on this, and CHCS has helped us with, our 5 MCOs asked 72 different kinds of questions around social determinants and health risk assessment, and only one overlapped among all 5 of the MCOs. And so we are putting into our contract starting in January a common 3 social determinants of health screeners around food, housing, and transportation, which I think are the most critical for the Medicaid population, and are working on doing that. And so I think this value-based payment change will really help get the care that's needed in the method. So that may be face-to-face, but it also may be through texts. It may be through phone calls. It may be through an AV thing. One of the other things that we've done to sort of help providers get there is for our Medicaid behavioral health providers, we've purchased Zoom licenses for a year so that they don't have to take on that, and we did that very early in the pandemic so that behavioral health providers could quickly connect to the patients that they needed to. And I think that's helpful, but I am super excited about our model, and we've had 8 payers in Washington sign on to a memorandum of understanding that they'll support this and keep the model going, which includes our 5 MCOs and 3 of the commercial plans that work with our employee and school employees. We also put it out for public comment. We had 129 people and organizations reply, and 87% said that they supported this model. And so we're pretty excited about that stakeholder work. There's more details to sort out. We've got the high level agreement, but I think it's the right direction for us.
That's great. I think clearly now is a time when capitation payments are really important. And we're just excited to see you all launch the model and track and share what you learned throughout the process with other states. I do want to quickly, before we open up to Q&A from the audience, so audience members, if you have questions for Dr. Zerzan, Dr. Labby, Dr. Kelly, please enter those now. But I do want to quickly, like maybe a minute each lightning round, want to get your perspectives on health equity and primary care, and just quickly, either, what have you been doing that you think has been impactful, or what are you thinking about doing in the health equity space when it comes to primary care to better support primary care practices and reducing disparities, being more responsive to communities of color? Would just like to get your quick takes on that question. So David Levitt, can I start with you first?
Sure. I mean, I'm certainly not an expert on how to deal with inequities or an anti-racist approach to primary care, which I think is an ongoing conversation. HealthShare has adopted as the focus of a strategic plan, leading with race, and that's that's opened up a conversation. Well, yes, we all agree with that. What does that actually mean? Clearly, it means a lot of training and a lot of awareness. We've been doing work around trauma-informed care in the state for 5-10 years. So that sort of builds on that kind of work. So we're familiar with that. Not that that's the same thing exactly, but it sort of opens up that space. But I think that we're more and more sort of asking, where can primary care deal with issues of systemic racism? And so it's becoming really concrete. Let me just give you one example of our thinking. So we know that there's what's called a preschool to prison pipeline. We know that mainly young boys, maybe young boys of color, get expelled from preschool because of behavior problems, lots due to family stress, to trauma, et cetera, and that they don't get prepared for kindergarten, they don't get prepared for school, and there's a whole pipeline of bad things that happen that end up, as it says, the preschool to prison pipeline. We also know that all of these kids are coming to our practices, and we also know that we see these kids when they're climbing up the walls and banging around the exam room, and we're not doing anything about it. And so the real question, one of the questions for us is, well, this is the first early step in the preschool to prison pipeline. Shouldn't we be focusing and shouldn't we be helping families who are in that kind of stress, and especially families who are, well, all our population is in poverty, but BIPOC populations. And so how do we help give culturally specific help to those who need it? And so when you start to think of that kind of processes, how are we actually enabling the processes that are going on that produce inequities? What's an anti-racist approach of primary care? It sort of opens up a different kind of thinking. So quite honestly, I think that's our work, is to sort of try and say, well, what processes, what structures of structural racism are we embedded in? And how do we change them? Another one is obviously the connection with criminal justice, which is a huge issue, and we're starting conversations about that. So it's not just becoming aware and education, it's actually, how do we change our model to deal with the threads that lead to these inequities, or reinforce them? Great.
Thanks, David. David Kelly, any quick thoughts about how you all are thinking about the opportunities to reduce disparities and improve equity in Pennsylvania?
Sure. The MCO level, we actually require the NCQA multicultural distinction. And I believe most of our plans will have achieved that distinction. And again, it's a program designed to really involve the entire managed care organization in really being more culturally and linguistically sensitive. At the practice level, one of the things that we are doing is we've identified across our program well-child visits in the first 15 months, high blood pressure control, and diabetes control. We know that there are defined inequities between individuals of color and the rest of our population. So we started last year, we actually developed an incentive program with our MCOs to close those gaps. And we want that to be taken down to the practice level where that is important. So we want our MCOs to identify, working with those practices where we know that there is a known gap in those well-child visits, as well as there's almost a 9% gap in high blood pressure control and about a 7 or 8% gap in diabetes control. So we're very focused right now on those measures. We have some other prenatal measures, but those are the measures that are pertinent to our primary care practices. So we really want to we want our MCOs to be working with our practices to stay focused on really identifying those gaps and then closing them. Thanks.
Great, thank you. Dr. Zerzanthul, any quick reactions on your part from Washington?
Yeah, I mean, I think it's really important, and we are working on this. We are hiring now for a health equity leader in our agency that I think is going to help us create some strategy around that. And I think it's one thing that, especially with COVID, we've noticed is a gap. We are also starting down a similar journey to Pennsylvania on looking at differences in our quality measures by race and ethnicity. We've discovered in that journey that there are 3 different ways to get on to Medicaid, and there are 3 different race ethnicity questions on enrollment, and the categories don't necessarily match. And so we're trying to clean that up, and our first measure that we've recently decided to focus on is around depression management, because that's one of our really big gaps. And I think that is squarely in the wheelhouse of primary care, and I think we can do a better job of both identifying and treating anxiety and depression, especially now with COVID when it's all a bit worse for everyone. So that's some of the work we're doing.
Great, thanks so much. Kelsey, I know that there are some questions queued up in the queue, so I want to hand it over to you to field some of those questions with our panelists.
Yes, of course. So it looks like some folks are interested in hearing more about COVID-19's impact on quality measurement. So a couple, I think, questions and considerations from the audience here. So one is, if you guys have thoughts on how you're thinking about trade-offs for certain quality measurements that relate to, in-person preventative services. Are those, how are you thinking about incentivizing those and measuring those given COVID? And then kind of perhaps the second piece here is, if you can share, are plans or states still incentivizing providers and NCOs through quality measurement this year, or are there kind of new policies in place given the, I guess, the chaos of the pandemic?
So I'll start off. We looked at our HEDIS measures, which actually was care rendered in 2019, but early on there were difficulties in doing chart review and whatnot. So the bottom line is we gave our plans multiple options that they could just rotate and use their measures from last year. The plans actually that decided to go out and get those measurements done were able to do that, and they actually showed significant improvement. And actually their payout in their MCO model was actually higher than we anticipated. So that was the challenge in 2019. 2020, again, maybe somewhat of a different challenge, and we'll have to see what happens. But I'll remind folks that NCQA, and we use many of our P4P measures to the providers and to our MCOs, our NCQA measures, because we use benchmarks and incremental improvement. And telemedicine has been allowed now in many of those particular metrics, including the well-child visits. So I think NCQA and others have been somewhat flexible in moving the needle, knowing that there are challenges to face-to-face visits because of COVID. But I do have grave concerns, especially when it comes to things like breast cancer screening, colorectal cancer screening, cervical cancer screening. I believe those are all down. I know immunizations are down, unfortunately, as are some of the other we know some of the well-child visits are down as well. So it is definitely concerning for 2020.
Yeah, I'll jump in that, yes, there are ways that these measures, you can use telehealth, and I feel pretty strongly that although performance is going to look different, we shouldn't let people off the hook and not measure quality at all. And so we're taking sort of a collaborative approach, and we're keeping going, but we're not stopping measurement of anything. And we are trying to find ways, particularly immunizations, of how do we increase immunizations in the population, because that's one place that there's been a drop off. And how do we provide other ways of getting needed care? And so, yeah, I think that's great. And it'll look different, but I think we'll learn from it. And that can only improve quality.
So just to add a bit from Oregon, the 2020 P4P program, which is significant in this point, was basically held in abeyance. We have to do the metrics, but the payment has just was paid out partially in order to help support the primary care practices through the period of the early COVID pandemic. I just heard this morning from the chair of our state quality metrics committee that they're thinking about metrics that would be appropriate during COVID, which is a really interesting idea if you think about it. So, I mean, one could think about, well, what's the percent of visits that are telehealth? What's the percent of visits that are chronic disease that are telehealth? So there may, given how bad 2021 is looking, we may not be able to get the same we may have the same issues around performance. Don't know, we won't know for months. But I think part of the thinking that we all ought to be engaged in is, all right, we actually are now in a different sort of framework with the telehealth stuff. We want to optimize telehealth. Maybe it's time to do a quick pivot for at least some of our measures that incentivize people to stick to that platform. I saw some data that showed that the number of telehealth visits have gone down and people are reverting back to regular primary care visits. Certainly in our population, where transportation is an issue, access is an issue, telehealth is a huge boon, I would think. And we know that from behavioral health as well. So I think an enlightened quality performance program may want to put in some things that actually incentivize the new things and not just the old things that we've been doing. And we have all these fine metrics from, but basically a metrics program says, where do you want us to pay attention? And I think that's the question for the metrics program is, where do we want them to pay attention right now? Because where you put money is where people put their attention. And what are the things that are actually transformative? And how do we make the metrics programs much more about transformation than simply quality measurement in a stable state?
Yeah, I think that's super important, especially the quality of the telehealth visits. We've been sort of pondering and struggling with that. How do we know that there's good stuff happening in those visits versus just sort of check the box? We don't have any answers, but I think that is sort of the next frontier of how do we know? And I think also being patient-centered about that. So how do we know, do people get the kind of visit they want? So if they want an in-person visit for whatever reason, can they get that? Or are they relegated to phone or a video visit? And if people want one of those other alternatives to in-person, are they getting that? And so we're really thinking about patient choice and preferences and how can you make sure that happens?
That's great. I know we are just at time, so I'm going to ask for a quick rapid round, 30-second responses from all of you all. And just, in your audience of peers in other states, like, where's the one thing that you think folks should be the biggest opportunities in the near term for promoting primary care innovation? So Judy, I'm going to turn to you first.
Okay, so I think getting the payers, getting employers, and getting the primary care providers all to lean in the same direction. And again, our effort in that is not just Medicaid focused. I think the Medicaid population will benefit from that holistic view of how do you improve and support primary care better. And that's what we're trying to do here. Thanks.
Thanks, Judy. David Kelly, your thoughts on the question?
Again, with the COVID pandemic, my biggest concern really is keeping practices open and maintaining access to care and high quality care as much as we possibly can. So right now, I mean, that's basic blocking and tackling to make sure that I talk to a lot of colleagues that are very concerned about their practices, and even in the larger health systems, we see that. So that is my biggest concern right now, is to make sure that we can find ways to keep those doors open and there's high, good fidelity care that's being rendered. So that's my biggest concern. And we have a whole bunch of value-based programs and regional health collaboratives, et cetera. But if you don't have the doors open and you're not providing good care, it's kind of hard to think beyond that. So that's really I'll say that's my short-term look over the next 4 to 6 months, but it's going to be vitally important, especially in some of our rural areas in Pennsylvania. So that's my biggest concern.
Thanks, David. And David Labby.
So I want to build on two things. It looks like we're going to be spending the next 4 years building back better. And it looks like, so I like that as a theme. And the other theme I liked was Judy's analogy about the internal combustion engine. I think the time is, I think our PCPCH standards, what we ask of primary care, are about the internal combustion engine. I think we should junk them all and start over. I think it's really time to say, all right, what should a primary care medical home, or whatever we call it, patient-centered primary care home, what should it look like? Because we have a whole new set of things we want from it. And we need to codify them. And we're just gonna make the wheel a little bit smoother. Maybe we buy a better tire on the old wheel, but that's not what we should be doing now. And the opportunity is to do something transformational.
Great. Thank you all so much for taking the time out of your incredibly busy schedules to share this with you all, with us. Appreciate your time and your innovation and all that you're putting into your work. For folks who are attending, please take 2 seconds to answer our survey. We deeply appreciate it. And we'll be following up with more information in January about the next phases of our work and opportunities to continue to learn together. So thank you, and have a good rest of your day.